cameras because we will be recording this session. Okay, let's begin. So, well, good afternoon, everybody, and thank you so much for attending our webinar today. I hope everyone can hear me okay. Any problems, just pop it in the chat and Billy Jo will let us know. So today you're here for the Supplementary Network Services Workshop for 2021 to 22. My name's Brett Keller, and I'm the Primary Care Facilitator for Newham. I think somebody's left their mic on. Could you mute your mic just to stop any interference? Thank you.
I think it's Hina.
Thank you. And also with us today we have Billy Jo, who's our Primary Care Support Officer, and she will be monitoring the chat and doing a lot of admin stuff. So the agenda for today, we're going to be talking about the Newham Supplementary Network Services. We'll have a quick recap over the PCN targets. We're going to talk about incorporated SNSs, and IT permitting, we'll give you a live demo of CEG searches and the SNS dashboards. Well, as if you need reminding, this last year we've seen unprecedented pressures on the health system due to the COVID-19 pandemic. The SNSs were temporarily suspended, as was QOF. And the challenges on general practice was that you were unable to see your patients face to face to do your long-term condition reviews, etc. And also, partly that was because there was a reluctance in patients in attending general practice too. We also saw delays in discharge summaries being sent to the practice, and that was from secondary care and A&E, as well as delays in patient treatments. So we're in what they're now deeming the COVID-19 recovery, and the CCG have started remobilising the SNSs. And what they're doing is they're taking a collaborative approach, and they built flexibility at the centre of this implementation. There will be some pressure still this year, and that will obviously be with the oncoming flu vaccination and introduction of COVID booster programme as well, which will aim to start at the beginning of September. CEG are currently working on searches for these, and so we'd let you know when those are available to copy over. Also, you need to restart your annual reviews if you haven't done so already. CCG is asking the practices to target their high-risk patients who will need ongoing proactive management. So that is your long-term condition patients. But also they would like you to prioritise them, and you can use our UCLP searches that we've put in to the folder. And that stratifies patients as low, medium and high risk, specifically in COPD, type 2 diabetes, CVD and AF. We've also got some APL tools which you may be familiar with, and the next slide will show you where those are. And obviously don't forget, we're here for support. So if any of this you're thinking we've not seen it before, just drop us a line and we'll help talk you through it and show you where everything is. Although you're being asked to use these tools, just remind you that practices still retain the discretion to identify other priority patients. So if you know of some patients who have social vulnerabilities and that's impacting on their health, then you are able to prioritise those. So this is a screenshot of where those tools specifically can be found in the folder hierarchy. So your APL tools will be in folder 4, which is clinical and screening tools. And then your UCLP CEG risk stratification searches are at the bottom there. So let's begin by having an overview of what this year is going to bring for you. The SNS year will actually run for 9 months, although we will call it a year. We all know it's 9 months now. So it's running from the 1st of July to the 31st of March. And the good news is that from the 1st of April next year, the SNS year will return to the 12-month period. So this will synchronise with QOF and make sure that the care is aligned with all the other services and schemes too. I know we've been asking for that for a number of years, so we've got there finally. The outcome measures have been replaced by what we're calling incorporated SNSs. So if you recall, the outcome measures were introduced in 2018, and this was to equalise GMS and PMS and APMS practices. It was for a 3-year period. So now these incorporated SNSs will be for all practices, and that's irrespective of your status as GMS, PMS or APMS. So everybody should be doing the same work. Now, in recognition of this 9-month period, the PCN targets have been reduced to so that there isn't an extra burden on practices to achieve higher targets. Here's a screenshot showing you the latest searches, and I would like to just point out, I know we sent an email around just yesterday to say that version 2.2 was ready to be copied across. However, it came to our attention this morning that the labs have actually changed the codes they're using for HbA1c. So we've had to quickly run in and add all those codes into our searches. So when you leave here today, if you could make sure that you copy over version 2.3, we will send an email round again. We'll send our bulletin this afternoon for those practices who aren't with us today. But again, apologies for all this extra work, but it wasn't notified to us. And thank you to Woodgrange Practice for highlighting that. Okay, now we're going to go through a summary of the changes for the coming 9 months. And as usual, what we'll do is we'll put to one side anything that hasn't changed. So case finding, CKD, coordinate my care, ECG, latent TB and post-cardiac review remain the same. This means we can now concentrate on the revised and new services. Okay, for ADHD, although there's no specific change to the specification, we just wanted to point out that the CCG have been explicit that advice or support from CAMS may be via telephone or email, and that's in light of COVID. So if that's your experience anyway, then that's fine. It's just that they mentioned explicitly. With cancer, the cancer care plans and reviews have been removed. Now this has been replaced with a PCN network peer review and a submission of the learning. The submission will be made by email and it's not due until the end of February. With COPD, there used to be a strict timeline for the post-exacerbation review to be within 2 weeks of being notified of a discharge. However, this was mentioned in the specification and we have emailed the CCG to confirm whether that's remaining or not. I haven't heard back from them just yet. But what we'll do is obviously as soon as we do hear back from them, we will send an email round. We'll make sure you're all aware whether that timeline is still there or not. For your diabetic LTC review, the strict timeline for the 8-care processes has been removed and that's confirmed. So you can do these anytime now within the 9 months. Okay, I won't go through them specifically, except to say that foot care examination, although it's always been in the template, this has actually been added as a payment line. And also, if you're aware, you have to do MDTs. We had a query recently from a practice. They weren't aware that there was a tick box in the template. So when you scroll right to the bottom of the template, you'll see this. And if you tick the box to say that you've had that discussion in an MDT, and then also scan a copy of the MDT review into the patient notes, just in case at a later opportunity, there might be an audit just to see that everything's taking place as it should. So you've got that evidence in the patient record. As well as the payment lines, there's also a number of diabetes quality markers. Now, they differ from the payment lines in that they will be monitored and reported on, but you won't necessarily get payment for them. So in diabetes, you must record pulse rhythm and rate, preconception advice given to women of conception age. I'll just pause for a moment. Okay. Please ensure that retinal screening is being accessed, and if you've asked patients to attend, make sure you record that you've done that. Sorry, could you mute your mics, please?
Could everybody mute their mics, please? It's disappearing at the side.
Thank you. Right, I'll carry on. Yes, I was just saying about retinal screening, make sure that you're advising patients to attend and you can record that on the template as well. What is new this year is that there is a requirement for a percentage of patients who are aged over 40 with no CVD history to be treated with a statin, and we have searches available for that too. Moving on to CVD for the LTC review, again, similar to diabetes, the strict timelines have been removed, so these indicators can be done any time within the 9 months. And again, as for diabetes, the quality marker for CVD is pulse rate, rhythm and rate. Moving on to mental health, there's actually been a change in the eligibility for the physical health checks. So patients on antipsychotic medication, but not on the QOF register already, they must have a core physical health check. So the search will look for medications, and those will exclude those who are already on the register. And so they're the patients you must call in. The physical health check consists of BMI, blood pressure and pulse check, cholesterol or Q risk, blood glucose or HbA1c, alcohol consumption and smoking status. A reminder that this actually still needs to be done for the patients on the SMI register because those are part of the NHS England returns, but this is specifically for the SNSs. As well as the core physical health check, you must also complete the additional elements, which are your nutritional and diet status, physical activity and exercise, substance misuse status, and a medication reconciliation or review. Now, when you're doing that, you must consider whether the patient should be on the SMI QOF register and whether the antipsychotic medication is still clinically relevant. If you must complete both elements, the core and the additional, to receive the payment. And also, it goes without saying that all necessary follow-up interventions should also be carried out where indicated by the physical health assessment, and also signposting to the national screening programme. So that's your breast, bowel and cervical cancer screening. To continue, practices must engage in primary care network mental health huddles as part of the mental health transformation programme. You would need to submit a qualitative reflection on learning and the work done with the transformation team and in the programme by the end of February. And also, patients on depot or other antipsychotic meds must have a 6-monthly GAS assessment, which is your Glasgow Antipsychotic Side Effect Scale, and that is in our template too for recording. Also, every time you give a patient a depot injection, record that in the template as well, because there is a payment for every depot given. Primary prevention, nothing's really changed here. Most of these elements can all be done within the 9 months. However, smoking status and smoking advice, if they're a smoker, should be on the same date as the review. Offering referral or signposting as appropriate, again, should be same day. Your CVD QRIS2 can be recorded within 3 months either side of the review, so 3 months before or 3 months after, and that's for payment. Now we have peer review and referrals, and this you may recognise as formerly being demand management. Nothing's really changed here, so I won't go over every piece because, as I say, nothing much changed, except to point out that instead of monthly reporting, now you are able to do quarterly reporting. And the next slide as well. This again, nothing's changed here. We've added it into the presentation just so that when we email the presentation to practices, you've got it all to hand. And then wound care, nothing's been changed yet, but this is a rolling 3-monthly SNS and will be subject to redesign within the year. Okay, just going to take a pause now for a moment just to see if anybody's put any questions in the chat or if they'd like to raise any questions. So please raise your hands and Billy Joe will come to you and ask you to unmute your mics.
So James answered a couple, but I can't see any hands up.
Okay, so we've had some questions that have been answered.
Yeah, and Mevish has said her slides are not moving. She's still stuck on.
Oh,
She's still stuck on mental health. Has everybody else's slide moved to any questions?
Yes.
Yeah. Maybe log out and log back in, see if that'll help.
yeah, rejoin.
I've got a question in the chat. Will we get from Barry? Will we get this all as a written spec? You should have already received it from the CCG. Gary or Nazar should have sent it out to you. I've got a few more questions.
Neil was asked the question, what is the wound care SNS, please?
So that's your dressings. When patients are discharged from hospital, you have the dressings and injections. That's been around for a few years now. And there is a wound care template specifically for this SNS.
It's actually a block per practice tariff, so
Yeah.
it would have been agreed with the CCG before you signed up for wound care.
Also, Priya and Neil's put the mental health, is it mandatory for attendance at the huddle? As we were told this was not happening.
Oh,
and was optional for PCNs.
I haven't been made aware of anything to that effect. I can confirm that with the CCG and get back to practices. Apologies.
Thank you, Priya. That'd be lovely. Just because a lot of PCNs, including Northwest 2, we don't even have a huddle yet that's been set up or anything else.
Okay.
So that'd be lovely if you could just find out for us, because they said that it was optional and there was nothing agreed with ELF as yet on whether it's going to be run across PCNs and if they're still just doing pilot projects.
No problem.
Thank you.
Yep. Thank you, Anil.
So I have a question about, I will continue working on COPD case finding.
Yes, nothing's changed with that.
Okay, so due to COVID, we're not doing the spirometry. So how can we do that?
So I presume whatever was happening last year, CCG will be aware that you're not doing spirometry, obviously, because of the air particles.
Yeah, because for the cough, they have taken, they have removed this thing, to do the spirometry as a mandatory thing. So, but for case finding, you definitely have to use the spirometer.
Yeah.
So is there any exemption or how it's going to work?
Unless you've heard otherwise, Jane, I can confirm with the CCG and let everybody know.
Please.
Yeah, I haven't heard
Okay.
of anything, so.
Yeah, we'll get back to everybody then with any updates we get from today's meeting.
Yeah, but I know for QOF, if the spirometry service is not available, there's an exception code for that.
Yeah.
For QOF.
So I'll double check if CCG will accept that.
All right. Thanks, Britt.
That's okay. Thank you.
We've got another one, Anne from Claremont. She said that she normally enters the information after the meeting for the MDT regarding diabetes. Is this still acceptable?
Yes, but you must go back into the template and tick that the MDT has taken place for that patient and then scan the notes in. You must scan the meeting notes into the patient record, obviously making sure there's no other patient details on there. Does that answer your question, Anne?
Yeah, hi, it's Anne. Thank you. I got the bit about the diabetes care plan ticking, but I always had a problem. Where can I actually get the MDT notes for me, the format for me to write on? I normally write it on a piece of A4. Or I take short notes and then I enter it into the patient's consultation as soon as after the meeting has been concluded.
And do you go into the template and tick that the MDT's happened?
Yes, yes.
You do, okay. I'm sure that would be acceptable as long as it's entered. The evidence is what they're after.
Okay.
I'm not aware that there's a specific format unless anybody else is aware otherwise.
Actually in PRIT, in BHR, we have got an MDT template and it'll tell you who's attended, like GPs, healthcare assistants, and I'm happy to put that into Newham if it's any help, and they can put the comments directly into the template.
Would that be useful?
With the names attended. Yes?
That might help, because at the moment all we just have an attendance form where we tick how many cases are discussed and discharges from the hospital, but even putting that into the template, because then then it'll be paper free and we go straight into the consultation via the template and fill things up? We could give that a try.
Yep, fine. I'll publish that for you by the end of the week, and we'll send out comms when it's available, and then you can feedback if it's any good.
Will do. Thank you very much.
Thank you.
Can I also mention, sorry, it's Zara here. So our MDT minutes are done by the MDT coordinator, and that usually get automatically added onto the emails. Isn't that how it's done, or is it a separate way of doing it as well?
Now, this is for the diabetes MDT, not the specific GP MDT.
Okay, that's fine. Thank you.
I have asked a question on the chat box.
Oh, okay. You can repeat it if it's easier for you to do.
It's about the wound care. You know, we are referring our patients to 7-day access for the dressings and the wound care. Are they ticking the boxes? Do they use the template on the system?
There is a template that they must use, yes.
But they should use. I haven't come across any patient, tick box. They have ticked the template anyway. They've used the template.
Okay, well, the template's been around for a good 2 to 3 years, probably as long as the service.
It's for the 7-day access. Because we are referring, our patients to their nurses, during the weekends.
Is that something? Is that something between the PCNs? Is it?
Yes, 7-day access.
Okay, I mean, we're
they want us, they want our patients to be referred to them. So we are referring the patients during the weekends, and some patients, if you don't have in your pharmacy, with our nurses. Right. But I can't see any wound care dressings are ticked on the template.
And then how are they sending that information back to you that they've seen the patient?
Just the free text on all records.
So then when you see that, are you able to go into the template and?
Yeah, but we don't really, because we don't really, every time, as soon as we refer the patient, we don't go with the patient's records and check the recordings, isn't it?
No, but if they have access to your
no, 7-day access, the asthma from NHC.
Yeah, NHC, so but at the moment
so are they aware of the template?
I don't know that they're able to see our template because they have different, they don't have resource publisher as we do. So I don't think they can see our templates. No, so you have to have some sort of internal process where you get the information back to record it. Right. But as Jane said, it's a block contract. So it's not paid per patient as such, but yeah, definitely clinically the information should be in the patient record.
Right. Okay. So probably we may have to, go back to their records and tick the boxes then. Okay. All
unless, right. As you say, unless if they've recorded it in the consultation, then clinically something's been done. But it is a block contract, so it's not done per patient seen. Right. If that's your query.
Yeah, they haven't been using the wound care template anyway. Yeah. Okay. All right then. We'll have to do something in-house. Okay. All right then. Thank you.
Okay, Mira, no problem.
You've got Barry said, sorry, he's not familiar with the demand management meetings. Is this PCM based?
Should we go back a bit?
If you don't want to put it, I'll check it.
Okay. All right, yeah. While Jay's checking that, shall we move on? Are there any other burning questions? We'll have another question session at the end if anything does come to mind. Okay, I'm going to move on.
Okay.
All right, we're going to have a very quick look at the practice versus PCN income for the next couple of years, just so that it sets the groundwork for how things are going to move forward, given that everything was suspended last year. So for the next 9 months, practices will get 90% of the payment for any activity that they perform. The PCN will get 10% of that if the outcome target has been met. Okay, so practices will get 90% of their activity, there's no target. PCN will get the 10% remaining if their own outcome target is met. And then in year 2, that will change to 80% payment for practice activity to the practice and 20% of the outcome target to the PCN. Now, where a PCN outcome target is set, only those practices within the PCN who've achieved the target will be eligible for the PCN payment. Practices will still get paid for their activity.
Okay, you're right, yeah.
Can everybody please mute their mics, please?
Thank you. Okay, the next couple of slides, I'm not going to go through in detail. It's literally just showing you the changes between the old and the new targets, bearing in mind it's a 9-month commission service now. If the service you're looking for isn't on here, it means it's either been removed or there's no change. So these are really the changes. And again, like I said, I'm not going to go through them. It's just there for you to have when we send you the presentations. Okay. Any quick questions on those couple of slides? If not, I'll move on.
Just to let you know, the presentations will be sent out after. A couple of people put that in the side. And I just got one Prit. Is the demand management dashboard same as the NIL? The Nelly?
The Nelly one?
Yeah.
No, it's Jane, correct me if I'm wrong, is it the what was it used to be called?
I'm not sure what the dashboard is now, because it used to be the Tableau dashboard, what we produced, but we haven't been asked to produce that for a couple of years now.
So that's the reason why I was asking Jane, Prit, and the rest of the colleagues. Hi, sorry.
Hi.
This is Vaishali here. I don't have my camera. I'll try, but
no, it's fine. Don't worry, Vaishali, you can speak.
It's just I was confused because we used Tableau before, Jane, Prit, and the rest of the colleagues, but we haven't had that for some time now in terms of demand management usage. And I don't know if there was a replacement dashboard, or what do we use in terms of discussion, even if it's a quarterly discussion, or what we were going to be measured against. So that was the question, guys.
I think I need to feed that back to the CCG, because we haven't produced any dashboards for this, as I said, for a couple of years now. And I'll speak to Nazar and Gary and get that clarified for you.
Thank you, Jane. That's really useful. One last question and addendum to that and previous bit of presentation, Prit, about the PCN and the practice target. Now, both come as a separate contractual thing, but in terms of overall contractual ask for each element of SNS, I know the SNS has that breakdown, but at some places the targets are different in terms of overall PCN population. So would we have anywhere to look at the searches, etc., to understand what our PCN target is versus what our individual practices target are? Assumption is if you meet your practice target, you'll meet PCN target. But is there, so if a practice did 100% and another one did 70, for example, does that mean PCN achieved its target because it balances out in averages? That was my other question.
No, they've changed it completely. That's what that's what it used to be now. So basically, Prit's going to do a demo of the dashboards, and that'll show you where your practices are at within your PCNs at the end. Is that okay?
Thank you, Jane. Thank you, Prit. Thanks.
Thanks, Jane. Okay, I'm going to move on to incorporated SNSs, and as we said, they were previously known as outcome measures. And if you remember correctly, that they there were separate indicators for GMS, PMS, and APMS practices. Apologies here, my spread, that's okay, I'm on the right page now. Now, these incorporated SNSs will be paid on £1 per weighted patient. The majority of outcome measures will be measured against 4 bandings, band A to D, which is, again, along the lines of what the outcome measures were previously. And here you can see the list, it's listed how the bands break down. There aren't any PCN outcome goals applicable for incorporated SNSs this year. So in the SNSs, clinical appointments, practices must offer a minimum of 16.5 clinical hours of appointments per 1,000 registered patients. For type 2 diabetics, a patient whose BP is less than or equal to 140/80 or HbA1c less than or equal to 58 and have been prescribed a statin. Anxiety, depression, you need to increase your uptake of patients into the IAP services across Newham. Epileptic patients, this hasn't really changed much, an annual review to include all of these elements, and your monthly clinical MDT meetings are still to be done. I think everybody did frailty last year too, so that hasn't changed. If it's appropriate, your review can be conducted with a geriatric-led service, and your review can include referral to specialist services and the creation of a CMC plan. Now, in our folders last year, we put an early identification tool, and this is for advanced planning for cancer, end of life, I should say. Now, you can use the patients in this. You can conduct appropriate care planning, add the patients to the end of life register if that's clinically appropriate, and also take appropriate actions with regards to referrals or making an advanced care plan using CMC. The patient surveys will continue, and practices need to achieve at least the percentage of good, in inverted commas. The Newham average for good is actually 57%. Sorry, my slides have gone funny. Yeah, so as I said, this 57% is the Newham average. Infant feeding, I think everybody was doing that before, so I won't go over that too much. And immunisations, nothing's changed. So immunisations are recommended nationally for children up over the age of 2 and under 3, and over the age of 5 and under 6. Sorry, could you mute your mic, please? Thank you. What is new is you have to offer children appointments. So practice needs to reserve at least 1 appointment per 2,500 patients to the maximum of 2 daily for direct booking by the Urgent Care Centre 111 or the parent or carer. CKD management, that's continuing. So is child health promotion regarding advice with dental and weight, and also the provider access and patient feedback survey. Now the next one is new, so you need to record appointment types. So these can be face-to-face, via SMS, online consultations, telephone, whatever you offer. And you also need to include the encounter types, so the role job category. These can include the new roles such as social prescribers, paramedics, pharmacists, etc. And hopefully this will benefit by a better understanding of the demand and the capacity and the skill mix within the practice. There will be a best practice guide, and this will be shared with practices centrally. Recording of ethnicity, this is new too, and this is to understand your practice patient demographics, which hopefully will help you reduce health inequalities and to improve outcomes for patients. There's also the new child asthma reviews. Now, you need to provide timely follow-up appointments for children aged 0 to 18 who have had an A&E admission or unplanned admission due to their asthma. Now, if you receive a discharge summary within 24 hours of the patient being discharged, and it's also marked with asthma follow-up required by GP, you need to review the patient within 48 hours of receiving this. If you receive the discharge outside of those conditions, you still need to review them, but you have within 3 to 5 days to do that follow-up. Okay, here you'll see the template, and if you look here at the top half of the template page, you've got the consultation type, and you'll see that the secondary care, asthma admission or attendance. So that's where you record that information there. You have a date box underneath, so you need to put the date that they were admitted or attended if it was A&E. Now, under the second lot of purple information text, you've got double-starred letter action by GP for hospital discharge or A&E attendance. So you need to tick that box. That will enable you to put the date that you received the discharge summary. And then the one underneath that, again, it's double-starred. It says patient followed up, and there'll be a drop-down list of appropriate actions. We're building searches for this too, so that will enable us to make the link within, whether the discharge, whether the review was done within 48 hours of discharge, or whether it was 3 to 5 days, again, depending on when the notification was received. Okay, just a quick screenshot here just showing you the folder of searches if you're not familiar with them already. And the next slide we just thought we'd put here might be useful, the current list of latest templates and the version numbers. So please make note of the version numbers or keep this to hand for reference, and make sure that if you are selecting something from your previously chosen template, that it is the latest version that you're using. Okay, as I said, IT permitting, I'm going to try and demo the new searches and reports for you, just that we've changed them up a bit. So you're probably all very familiar seeing them the same way. And if you've had a look at them recently, you might think, what have they done here?
Sorry, just while you're getting that up, can I just put in about the template? So the SNS template has still got information from last year's SNSs. I'm having major issues with EMIS trying to update the template. Every time I try and update it, it crashes. So what's happening is I have to strip all of the concepts out and I'm having to rebuild the template. So if you can just bear with me, I'm doing it as soon as I can. I've been working on it for about 2 months, but as I said, it's just been an absolute nightmare. But it is in process and we'll try and get it out to you as soon as possible.
And also we have raised it as a major clinical risk to EMIS too, because obviously, you know, everything has to be up to date and contemporaneous. So it's not that we're just waiting for EMIS, we have escalated it. Okay, so can everybody, I'm hoping everybody can see my EMIS screen here now. And I'm in the SNS activity folder, which, as I mentioned earlier, is now version 2.3. So please do go back to your practices, make sure that you've popped the correct one into your practice domains. You see there's 2 folders in here. So you've got the SNS activity searches and you've got recall searches for Accurix. What I'm going to do is I'll quickly show you these ones first. And what we've done is we've put in for recall, you obviously don't want to be recalling patients who've already been reviewed. So we've excluded those who've already had a full review and even a partial review, so that when you send these out, only patients who've not been in to have any kind of review will be invited. So that's where you can find that information. Obviously, we don't have patient numbers here because we only have a dummy system, but once you run it in your practices, your populations will be there. And then just to go back to the SNS activity folder, all of these searches now, we used to have validation reports before, and that was a different folder that practices had to go to. So we actually had a really good suggestion from Star Lane to say, could we not incorporate it into one? So Jane has been working on these with Star Lane. And as you can see, so we'll take the first one, for example, you've got eligible for primary prevention review. Then you've got patients who've had the annual review. You'll have patients who've had a complete review, so therefore your payment's guaranteed. And then here at the bottom, you've got incomplete annual reviews. So a review's been done, but some elements of that review are missing. And if you go into the report here at the bottom and do, which I can't do because it's not a live system, if you do view results, that will bring up a spreadsheet and it will, wherever the gaps are, that's what you're missing for payment. So it should enable you very quickly to be able to see what you need, who you need it from, and if you're still within any specific timelines, if it's still achievable. Okay. And going back to the presentation. We'll do a demo now of the SNS dashboard. And a quick reminder as well of the link where you can find these, because the dashboards have moved. So if you've got an older link, that won't give you the dashboards anymore. So this will be in your packs when we send the presentations out to you. So you click on the link there and you've got a new username and a new password. Now, as it says there, to increase security, this link is hidden from the menus on our website. So if you go to our website and try to navigate from there, you won't see a link to this page, because obviously anybody who does that, they'll have the username and password. So we suggest that you bookmark it so that in future when you go into your Internet Explorer, you can just take it from the bookmark and then pop in the username and password, which is what I have done here. Just to speed things along, I did it already, just in case it didn't work further down the line. So this is your landing page. Once you've logged in, this is what you will see. You'll see we've got a number of COVID vaccination reports at the top. Then you've got your NEL-wide dashboards here. So you've got your AF, cancer screening, etc. You've got your investment and impact fund, structured medication reviews, the learning disabilities, this will be the NHSC one. And then obviously flu vaccination uptake, which is on the horizon too. If you move back up to the top, you'll see here you've got all your boroughs listed. We want Newham. So you click on your Newham borough, and here you'll have your SNS and public health and all the other locally commissioned services, the dashboards. Just want to point out that you do have the, where's it gone, the outcome measures still, but those will be the old dashboards. Eventually they will be moved to the archive, which can be accessed here from the bottom. So what we're going to do is we're going to just have a quick look at the supplementary network service dashboard, because that is now incorporating what used to be outcome measures. So I've already got that open again, just to save time. So when you download it from the website, it will open like this. You will need to enable editing, and sometimes it asks you to enable content too, and it does. So just do that. It doesn't take too long. So here at the bottom, you'll see all the all the tabs that you can navigate to. The first one just has a summary of everything. Bear with me if you're familiar with this. I won't spend too long on it. You've got drop downs here, so you've got your NUM totals, you've got PCN totals, and then you have practices. So you can go drill down to whichever level you wish to see, and all your services are here. So it's just a matter of scrolling across. You have a summary tab, which is just all that data. Again, you can look at it by PCN. If you click on the PCN, then you get your practices underneath here as well. But this is the one you're probably going to be interested in at a network level. So here you have all your network buttons. So you got your South 1, Central, NUM Central, etc. They're all there. You can navigate towards them, and as you can see at the bottom here, all the practices will change accordingly. In this drop down here, you've got all your services. So if you choose a service from there, these graphs will change accordingly. So if you see here at the top, here says primary prevention and patients with full primary prevention review. You won't see that data here. You'll need to scroll across to find the actual data, because it's just a longer template. There it is, primary prevention. But the graphs will change. And then you've got activity detail, which is again just, you know, all your measures at the top, so you can see how you're doing. Then these are where the quality markers will be, and again you've got your drop downs, and as you change them, the practices will change there too. Then you've got your wound care elements here, where if you're in doubt whether how you're performing, you can just check here. And then you've got a tab here for latent TB quality as well. Just want to remind everyone again, if you're not already aware, we are here to support you in anything we've talked about today, whether it's dashboards, APL tools, the searches, the templates, any tools that we provide. We're here to help facilitate your understanding so that you make the best of, you know, what we're providing for you. And obviously, if you have any suggestions, we're open to those too, because, you know, that's how we improve our tools. We don't use them with live patient systems. And, you know, often we get very good suggestions, and that benefits the whole of Newham. Okay, that actually concludes my presentation today. So are there any more questions on anything? It doesn't have to just be about incorporated SSS. If you've come, you know, thought of a question for something else, then please feel free to raise your hand or pop it in the chat, whatever you feel more comfortable doing.
There's nothing in the chat at the moment, Priya.
Okay.
We'll just see if anyone puts anything in or puts their hand up, but I can't see anything at the moment.
Are they still there?
Yeah, just give them a few minutes. I'm sure they'll think of something.
I know, they're just digesting. We've got time yet anyway. We've got about 10 minutes before we're due to close. If you don't have any questions and you need to leave, of course, please feel free. As we said, we will put the presentation on our website if you want to go over it, or if you want somebody else in the practice team to listen in, you can do that, and we'll let you know when that's available. And we'll also send you the slides as well, so that, you know, you can refer to them as and when. And we will also get back to you on those issues we talked about earlier that we didn't have an answer to.
And feedback forms as well, Prit.
Oh, feedback forms. Yes, we will be emailing feedback forms. It does help us to know whether you find these sessions useful, anything really, whether they're too long, too short, if there's anything else you'd like us to do workshops on. So again, you know, we can help you if you let us know what you need. I don't think there's any questions then, is that right, Billy?
I think Dr. Maddie Pelly has just said there's a problem getting patients into the surgeries. Actually, you can do the face-to-face or video.
Yeah.
The CCG will accept them if it's face-to-face or over video, so it doesn't necessarily mean that you have to get a patient in.
No other comments at the moment, Priya, and I can't see anyone got their hand up.
Oh, well, that's lovely. Hopefully,
you just got a lot of thank yous from presentations, very helpful. So,
well, thank you very much. But please, if you do get the feedback form, please do fill that in too. And I'd like to thank you too for attending today. And it was quite a good session, quite informative, and I hope you found that too. You know where I am. Anything at all, drop me an email and we'll get back to you. We are offering practice visits from September onwards, and these will be virtual, so we can do them via Teams still. So again, please let us know if that's the case. They're just as effective as actual practice visits. Sorry.
There's one question, Priya, from Christina. Albert Road, can we review be done telephone as well?
Yeah, telephone, face to face.
Yes.
Yeah. Video. Okay,
obviously,
then.
Yeah,
oh,
obviously, if you need to do like a pulse check, you can't do that over the phone. But anything you can do over the phone, you can do over the phone.
Yeah. Okay, well, in that case, I'll wrap things up. Thank you again for your time and for attending today. And as I say, we're here for you. Drop us a line, whatever you need. Thank you.